Addiction is best understood as a human condition expressed through specific lives and contexts. Among those contexts, women's health, pregnancy, and parenting require particular attention because biology, caregiving roles, legal structures, and stigma interact in ways that can magnify risk and narrow options. A system that treats addiction as a trait of a drug will miss the determinants that actually govern outcomes for mothers, infants, partners, and extended families. A system that treats addiction as a human condition, shaped by pain, stress, relationships, and resources, can design pathways that protect life, preserve attachment, and support development across generations. Gendered experience changes exposure, detection, and response. Women experience higher lifetime rates of sexual violence and intimate partner violence than men, higher prevalence of certain anxiety and depressive disorders, and child-rearing expectations that increase contact with schools, clinics, and social services. These factors alter the timing and form of first help seeking. Many women present later than men because stigma is harsher, because caregiving responsibilities limit time for appointments, and because disclosure can threaten custody or safety when a partner is controlling. In many regions, treatment programs are not structured for childcare, transportation needs, or confidentiality concerns. When systems ignore these realities, harm escalates. When systems adapt, offering childcare on site, aligning hours with school schedules, providing private entrances, coordinating with domestic violence services, engagement improves. Biology also shapes course and care. Hormonal cycles influence mood, sleep, and pain sensitivity, which can in turn affect cravings and relapse risk. Pharmacokinetics differ by sex. Body composition, gastric emptying, hepatic metabolism, and renal clearance produce dose and side effect differences. Pregnancy requires further adjustments. Plasma volume expands, protein binding shifts, and metabolic pathways accelerate, changing effective dosing for many medications, including medications for opioid use disorder. Postpartum physiology shifts again. Treatment that fails to account for these changes underdoses or overdoses. Treatment that measures function and symptoms and adjusts accordingly improves stability. The concept of telescoping describes the observation that, for some substances and some women, progression from first use to dependence and to first treatment contact can be faster than in men. This pattern reflects multiple forces: social secrecy driven by stigma, self-medication for trauma, faster access to prescription sedatives through healthcare channels, and the use of high-potency products in concealed settings. Telescoping is not destiny. It is a reminder to build detection and help earlier in clinical pathways and to remove barriers that prolong hidden use. Pregnancy changes the moral and legal environment around addiction. A pregnant patient may delay care out of fear that disclosure will trigger punishment, custody loss, or criminal charges. Policies that criminalize substance use in pregnancy produce predictable results. Late or no prenatal care, delivery out of hospital, and increased mortality for mother and infant. Policies that guarantee confidential, non-punitive access to prenatal and addiction care produce different results. Earlier entry, better monitoring, and safer births. A system committed to life and development aligns with the latter approach. A practical framework for care begins with universal, non-judgmental screening in reproductive age care, prenatal visits, emergency departments, and primary care. Screening should include alcohol, tobacco, opioids, stimulants, cannabis, and sedatives, because polysubstance use is common and because combined depressants amplify risk during pregnancy and postpartum. Screening tools should be brief, validated, and paired with clear pathways to assessment and treatment. The purpose is not to sort the worthy from the unworthy. The purpose is to open a door to services that reduce risk for two linked patients. Assessment must address more than substances. Depression, anxiety, post-traumatic stress, and intimate partner violence occur frequently and shape safety and adherence. Housing, food security, insurance status, transportation, and childcare capacity determine feasibility of any plan. Legal history and outstanding warrants affect attendance. Immigration status influences willingness to engage. Confidentiality must be explained clearly, including mandated reporting thresholds and the difference between voluntary information sharing and required disclosures. Many patients decide whether to continue after learning whether a clinic will call child welfare agencies for a positive test alone or only when safety concerns are present. Transparency builds trust. Ambiguity produces avoidance. Medication for opioid use disorder during pregnancy lowers mortality, reduces illicit use, stabilizes physiology, and improves prenatal care attendance, compared with unsupported withdrawal. Methadone and buprenorphine are the principal options. Dosing often requires adjustment upward as pregnancy advances because of pharmacokinetic changes, then adjustment downward postpartum as physiology returns toward baseline. Abrupt discontinuation is unsafe and increases risk of relapse and overdose. These medications do not treat every problem, but they provide a stable platform on which prenatal care, mental health treatment, and social support interventions can rest. Labor and delivery require coordination between obstetrics, anesthesia, pediatrics, and addiction clinicians. Pain management is possible and necessary. Regional anesthesia, non-opioid analgesics, and, when appropriate, supplemental short-acting opioids can be used without undermining maintenance therapy. Mixed agonist-antagonist analgesics that precipitate withdrawal should be avoided. Clear communication prevents conflicting instructions. The presence of addiction does not disqualify a patient from appropriate analgesia. Withholding adequate pain relief increases trauma and deters future care. The neonatal period demands careful, humane practice. Infants exposed to opioids in utero may develop neonatal withdrawal. Non-pharmacologic approaches, rooming in, skin-to-skin contact, quiet environments, frequent feeding, reduce symptom severity and hospital length of stay. Pharmacologic treatment, when necessary, should be delivered by standardized protocols that allow dose adjustments based on function rather than reflexive escalation. Breastfeeding is compatible with methadone and buprenorphine in many cases and can reduce infant withdrawal when no additional contraindications are present, such as uncontrolled polysubstance use or specific infections. Policies should support lactation counseling and avoid blanket prohibitions that remove a safe and beneficial option. Alcohol in pregnancy carries risks distinct from opioids. Fetal alcohol spectrum disorders reflect brain and organ development affected by exposure. The safest message remains abstinence from alcohol during pregnancy, but messaging should avoid shame-based tactics that deter prenatal care. Tobacco use increases miscarriage, placental complications, and low birth weight. Cessation support, nicotine replacement therapy where appropriate, and counseling reduce these risks. Cannabis and stimulant exposures present additional risks and should be assessed and addressed through education and treatment that acknowledges the reality of use rather than imagines it away. A postpartum period is a high-risk interval for overdose and relapse. Sleep deprivation, pain, hormonal changes, and abrupt loss of clinical contact after delivery can destabilize patients who were engaged during pregnancy. Insurance coverage sometimes lapses shortly after birth in jurisdictions without extended postpartum benefits, severing access to medications and visits. Infants' medical needs accelerate scheduling conflicts. A coherent plan anticipates these dynamics. Extension of insurance coverage for at least 1 year postpartum, scheduled follow-up within 1 to 2 weeks after delivery, continued or adjusted maintenance medications, and direct connection to pediatric care that aligns appointments with maternal care to reduce travel and time burdens. Child welfare systems influence family trajectories. When the default response to a positive toxicology screen is removal, engagement falls. When policies distinguish between unmanaged risk and managed treatment, especially when the parent is in consistent care and safety plans are in place, reunification rates improve and infants remain with primary attachment figures. Plans of safe care, where used, outline roles for healthcare, family, and social services. The plan identifies supports, home visiting, lactation consultation, parenting groups, peer mentoring, medication continuation, naloxone access, and specifies how risks will be monitored and addressed. Participation should be collaborative, not coerced, to the extent possible within legal frameworks. Domestic violence dynamics require explicit attention. Partners may sabotage treatment, withhold transportation, threaten disclosure to authorities, or force unwanted sexual activity. Safety planning, confidential communication channels, and collaboration with shelters and legal aid must be integrated into care. Clinic design should prevent partners from controlling all contact with staff. Separate rooms, private check-in, and the ability to signal danger are practical features. Staff should be trained to recognize controlling behaviors and to ask discreet questions that open the door to support. Housing remains foundational. A pregnant or parenting patient without stable housing faces obstacles storing medications, breastfeeding, attending appointments, and avoiding victimization. Housing-first programs that do not require abstinence as a condition of entry reduce mortality and improve retention in care. Recovery-oriented housing serves others who prefer substance-free environments. Oversight should guard against exploitation and ensure rules reflect evidence rather than moral theater. Eviction as a response to relapse increases risk. Step-down supports, landlord engagement, and mediation prevent displacement that would otherwise cascade into child welfare involvement. Childcare is not ancillary, it is a clinical requirement. Without childcare, attendance drops. On-site childcare, partnerships with licensed providers, and stipends for family caregivers convert theoretical access into real access. Scheduling aligned with school hours and pediatric appointments reduces conflicts. Telehealth fills gaps for brief follow-ups, but cannot replace in-person services that require examination or procedures. Programs that assume a free adult will be available to watch children exclude households headed by single parents or households with complex work schedules. Pediatric care intersects with addiction care at multiple points. Pediatricians and family physicians monitor growth, development, vaccination, and feeding, while also serving as nodes for maternal screening and referral. Lactation services support feeding decisions consistent with safety and maternal goals. Home visiting programs reduce isolation, identify early developmental concerns, and provide coaching on sleep, soothing, and safe storage of medications. These services should not be contingent on abstinence. Contingency creates perverse incentives to hide lapses and avoid contact in periods when support is most needed. Family planning respects autonomy and reduces risk of unintended pregnancies during unstable periods. Long-acting reversible contraception is an effective option for many, but choice must be genuine. Coercive practices have a long and damaging history. Counseling should be voluntary, neutral in tone, and offered in the context of broader health goals. Postpartum contraception can be initiated before discharge when desired. Access should not depend on ability to pay. Insurance coverage and clinic processes need to simplify, not complicate, uptake. Work and income stabilize parenting. Supported employment models place participants in jobs with coaching that continues after placement, allowing on-the-job problem-solving. Apprenticeships and short-cycle credentials align with treatment schedules and produce measurable wage gains. Employers benefit from policies that permit confidential disclosure of relapse risk, provide medical leave for stabilization, and allow graduated return to work. Job loss during pregnancy or postpartum increases stress and risk. Job retention with support counters both. Legal systems can destabilize or stabilize. Arrests for possession or for conduct linked to unmanaged addiction interrupt prenatal care, sever family contact, and increase the risk of birth in custody. Where incarceration occurs, medications for opioid use disorder should be continued or initiated, prenatal care maintained, and liaison with outside clinics established before release. Post-release, transportation, identification documents, and a scheduled appointment prevent rapid deterioration. Courts that offer diversion to treatment for eligible charges monitor progress with realistic expectations and recognize relapse as a clinical event rather than as a moral failure produce better outcomes for families than courts that rely on sanctions alone. Measurement aligns rhetoric with reality. Programs serving pregnant and parenting patients should track early entry to prenatal care, receipt of indicated medications, overdose events during pregnancy and postpartum, low birth weight and preterm birth rates, neonatal withdrawal length of stay, breastfeeding rates where appropriate, emergency department utilization, housing stability, family preservation and reunification, and maternal employment or education. Disaggregation by age, race, language, and geography reveals inequities. Risk adjustment prevents penalizing programs that accept higher acuity patients. Public dashboards build accountability and public will. Cultural narratives influence practice. When addiction in pregnancy is framed as moral failure, caregivers hesitate to ask for help, clinicians avoid complex conversations, and public systems default to punishment. When addiction is framed as a treatable condition, prenatal clinics become gateways for stabilization. Hospitals standardize compassionate neonatal care, and child welfare agencies work with families to create safe plans rather than defaulting to removal. Media coverage that replaces spectacle with service, listing clinics, hours, and helplines, moves communities toward this posture. Training and workforce readiness determine capacity. Obstetric clinicians need preparation in addiction pharmacotherapy, withdrawal management, and trauma-informed practice. Pediatric clinicians need preparation in neonatal withdrawal assessment that prioritizes function and family involvement. Addiction specialists need preparation in reproductive health. Social workers require knowledge of domestic violence dynamics, housing systems, and benefits navigation. Peer workers who are mothers in recovery bring credibility that cannot be substituted with generic messaging. They need supervision, career ladders, and compensation that recognizes expertise. Doulas trained in addiction care improve engagement and satisfaction during labor and delivery, and can link families to postpartum supports. Ethics and rights must remain explicit. Consent processes should be comprehensible and documented. Privacy protections should be respected while enabling coordinated care through appropriate consents. Policies that deny pain management during labor because of addiction history are unethical. Policies that terminate parental rights for a single positive screen absent safety concerns violate proportionality. Involuntary holds should be reserved for imminent danger and paired with rapid transition to voluntary services. Programs should articulate grievance procedures and respond transparently to complaints to maintain trust. Technology reduces friction when applied with care. Electronic records should embed clinical decision support that flags drug-drug interactions, dangerous combinations, and gaps in vaccination or screening. Prescription monitoring data should be displayed within the ordering workflow to inform decisions without forcing separate logins. Telemedicine appointments should include early morning, evening, and weekend slots to match caregiving schedules. Secure messaging allows quick adjustments for dosing, wound care, or lactation concerns without requiring travel. Privacy protections must be maintained, particularly when a controlling partner monitors devices. Infectious disease integration is not optional. Hepatitis C treatment can be delivered during pregnancy in some settings under protocols that weigh risks and benefits. At minimum, rapid linkage postpartum is necessary. HIV testing and treatment must be routine. Vaccination for hepatitis A and B should be standard. Wound care associated with injection should be available in clinics and via mobile teams to prevent hospitalizations and amputations. Dental care should not be neglected. Untreated dental pain fuels use and undermines nutrition and sleep. Nutrition, sleep, and physical activity are not side notes. Pregnancy and postpartum require caloric and micronutrient support, guidance on anemia, and screening for gestational diabetes. Sleep deprivation after birth is ubiquitous and destabilizing. Coaching on sleep strategies and shared care plans reduces overload. Gentle activity improves mood and function where medically appropriate. Programs that ignore these basics sabotage their own aims by allowing preventable drivers of relapse to go unaddressed. Adolescents and young adults who are pregnant require modifications to the general plan. Confidentiality rules must be explained in detail. School continuation, childcare, and transportation need proactive problem solving. Fear of family reaction may be intense. Counseling must create space to plan disclosure safely. Youth in foster care need continuity across placements and after-hours access. Legal guardianship arrangements complicate consent. Staff require training to navigate these realities without delaying care. Older parents carry different risks. Polypharmacy increases interactions with alcohol and sedatives. Chronic pain and sleep disorders are common and often treated with medications that increase risk when combined with opioids or benzodiazepines. Social isolation after bereavement or retirement can drive use. Geriatric clinics and home-based primary care should include substance use screening and careful deprescribing protocols tailored to physiology. Pacing of tapers should be slower, with attention to cognition and falls. Community settings beyond clinics matter. Libraries, shelters, food pantries, and faith organizations can host training in overdose response, safe storage of medications, and infant care basics. Restrooms in public buildings may become overdose sites. Staff training and availability of naloxone reduce deaths. Transit policies that allow transport of syringes and medications without harassment facilitate engagement. Housing authorities that coordinate with clinics to manage noise, visitors, and lease conditions reduce unnecessary evictions. Financing determines whether plans can be executed. Fee-for-service payment rarely covers care coordination, peer work, home visiting, transportation, or childcare. Blended and value-based models can tie a portion of payment to retention, neonatal outcomes, family preservation, and maternal employment or education, adjusted for case mix to avoid cherry-picking. Medicaid coverage extensions through 1 year postpartum increase continuity. Grants should fund startup of integrated prenatal addiction clinics, with operating budgets sustained through insurance once volume stabilizes. Settlement funds linked to opioid litigation should prioritize durable infrastructure rather than short campaigns. Prevention begins before pregnancy. Reproductive age care should include routine discussion of substance use, mental health, contraception, and violence in a confidential, non-judgmental setting. Workplaces that offer paid leave and predictable scheduling reduce stress that drives use. Schools that teach emotional regulation and media literacy equip future parents to manage distress without substances. Community norms that support asking for help without fear of humiliation shorten the time between first risk and first contact with care. Measurement should trigger course corrections. If engagement during pregnancy increases but postpartum overdose rises, coverage and follow-up intervals need revision. If neonatal withdrawal length of stay remains high, despite rooming-in protocols, staff training, lactation support, and environmental conditions need attention. If families are separated at high rates despite parental treatment engagement, child welfare criteria and judicial practices require review. If a clinic shows low breastfeeding rates in eligible dyads, lactation resources and messaging should be reworked. Continuous improvement replaces guesswork with adjustment. Public communication should replace spectacle with service. Announcements should include clinic addresses, hours, and transportation options. Explain how to obtain medications. Clarify that seeking help will not automatically trigger punishment. And provide hotlines that are answered by trained staff. Media should avoid images that exploit suffering or reinforce stereotypes. Stories that highlight successful family preservation and safe neonatal care recalibrate public expectations. The overarching theme remains constant. Addiction in women, pregnancy, and parenting is not a narrative about substances alone. It is a narrative about safety, attachment, time, income, housing, and access to consistent, respectful care. Lives improve when help is immediate, non-punitive, and oriented toward function and family preservation. Infants thrive when caregivers are supported to stabilize, bond, and build routines. Communities benefit when mothers remain alive, housed, and employed, and when children remain in safe homes connected to familiar caregivers. Those outcomes are not speculative. They are visible wherever systems align practice with the human realities that shape behavior. A coherent program turns principles into routines. Prenatal clinics screen and start indicated medications the day risk is identified. Hospitals coordinate pain management and neonatal care without drama. Pediatric visits become opportunities to support maternal stability. Home visiting programs knock on doors consistently. Child welfare systems distinguish between unmanaged risk and managed treatment and prefer family preservation when safety permits. Domestic violence services integrate with clinics instead of standing apart. Housing is secured before a crisis displaces a family. Employers protect jobs during stabilization and return to work. Courts support treatment and measure progress by safety and function. Data are published, inequities are corrected, and budgets follow results. This approach does not promise ease or perfection. It promises fewer funerals, more reunifications, more infants going home safely with primary caregivers, and more parents sustaining ordinary routines without arranging life around a substance. It accepts that lapses occur and designs responses that prevent catastrophe. It respects autonomy while building structures that make healthier choices more available than harmful ones. It treats addiction as a human condition and structures care accordingly across pregnancy and parenting, where the stakes include the next generation's first experience of safety and trust.